Rabia, I'm not recording. I'm just kidding.
Okay.
Why are you so shy?
Awkward. Not shy, awkward.
Rabia is my top student.
Aww, that's such a lie, but thank you.
I didn't say top in grades.
Still, thanks.
Top can mean many things, so that means you're a coolest top student. Okay guys, let's go. How much time do we have? What time is it?
Oh, you want to tell the students you're going to talk to?
I did already. Yeah. So this is good, right?
Yeah.
Okay. Why is it not? Wow. So stubborn. Skype wants you to use them. I don't need it anymore. I can delete it now. Right?
I don't know if you can delete it on Windows 8.
At least I can get rid of it here.
You can keep it from starting up.
Yeah, that's what I should do later. Okay guys, let's go. Let's go. Okay, I need to... Can somebody write... Because right now what I want to do is I'll sort of give you a syllabus for Tuesday's exam. Okay, so whoever writes it, please email me the topics. Okay, I believe there will be one question on Fragile X for sure. Okay, Fragile X. Do I need to go over Fragile X? No. Okay, so that's done. I believe there will be a question on Down syndrome. That's 2. Do I need to go over Down syndrome? Because we just did that, right? But now, please understand, ALL, just quickly, it stands for Acute Lymphoblastic Leukemia. If you know the name, what it means, I think you should be successful. Acute means sudden onset, now, new, fresh, not long term, not chronic. Lympho, what does lympho mean?
Lymphocytes.
Very good. Lymphocytes, which means T cells. Very good. Lymphocytes are T cells or B cells. Natural killer cells as well, but not so important. So let's just focus on this. T cells and B cells. Now, second thing, blast. Don't blast your music. What does blastic mean? Immature. Immature. So anybody who blasts their music in their cars and stuff, they're immature. Okay. Okay. So immature. I think Isba blasted her music in the car, right? I'm gonna pay attention next time. Okay, so now that's what blast means. So that means T cells and B cells are immature. You know, when you're immature, would you get a job in cardiology or hematology, whatever? No. That means you're not functional. Immature cells are not functional. They won't be able to do their job. B cells are supposed to produce what? Antibodies. B cells are supposed to produce antibodies. Okay? B cells are supposed to produce antibodies. And antibodies very specific to each antigen. If these antibodies see me, they'll produce anti-Munir antibodies. If they see Nina, anti-Nina, anti-Mazen, and so forth. These are short names, so it's easier for me to pronounce. Now, I mean, some of you guys' names are too long, so Ali is short, so I'll say that too. T cells. What do T cells do? Now you have two types of T cells: cytotoxic or T helper cells. Both. Very good. Now let me write down, then you can tell me. So T helper cells or T cytotoxic cells. So, what were you saying, Mohammed? Very good. So T helper cells simply call other cells to the site of inflammation. Cytotoxic T cells, what do? They kill viral infected cells. at the end of the day, most 95% of ALL are B cell in origin. 99%, oh, that's too much. 95%, 90 to 95% of all ALL patients are B cells leukemias. Okay, B cells. Now, let's go to Luke. Luke. Okay, I don't want to say anything more. What is emia? Blood. So that means increase. Luke means white, so that emia means blood. So white blood cells. White blood cells, that's what leukemia means. Whenever you use the term emia, it means increase in blood. It doesn't just mean blood, it means increase. Okay, unless you talk about hypoglycemia and hyper, but in this case it means increase. So I have lymphoblastic leukemia. Leukemia is cancer of white blood cells. In this case, this cancer is mostly primarily of lymphoblast, immature white blood cells. Which white blood cells? Specifically B cells. B cells. Which means what though? That means your immune system is now defective. Because these are immature cells, they cannot protect you against bacteria, especially bacteria. Whenever we talk about antibodies, think of bacteria. Okay, antibodies supposed to protect against who? Bacteria. Against viruses, you're okay because T cells is usually normal in this case, in majority of cases. So you won't have increased risk of viral infection. You will have increased risk of what? Bacterial infection. But at the end of the day, none of this is a problem, believe it or not. When we think of acute lymphoblastic leukemia, there's some basic knowledge that we need to understand in order to understand these leukemias. Remember, what did I tell you? Number one leukemia in children. Number one cause of death in children. Overall, you know, in my age group, probably the number one cause of death is accidents. At the age of 50 or 60, let's say, number one cause of death is cardiovascular diseases. In children, number one cause is what? Leukemia. More than accident, more than anything else. Okay, maybe in my age it's depression too. I think so. Yeah, in this age group, usually people, because they want to achieve so much, they don't, and then there's all these issues, they go through depression. Yeah. Midlife crisis? That's what you call me, midlife?
Isn't that what it's called?
I think so. I don't accept it. It's okay. Okay, so now, B cells, where do they mature? Where are they produced? Where are they produced? Bone marrow. T cell thymus, T for T. That's what they call T cells. B cells, they mature in bone marrow and they're produced in bone marrow. So let's say here is bone marrow. Okay. Now all cells are produced where? In bone marrow. Red blood cells, platelets, and white blood cells. The origin of all blood cell is bone marrow. In adults, of course. In newborn, it's mostly liver, and then in the first 3 months of pregnancy, it is yolk sac, so it changes. But in adults, it is what? Bone marrow, bone marrow, bone marrow. The source of blood cell is what? Bone marrow. So in bone marrow, you have stem cells. They can change into become RBCs or platelets or white blood cells. Are we okay with that? Okay. Now, white blood cells, when they mature, they will go where? Into circulation. Immature cells are only found in bone marrow. Now, when you have too many white blood cells and they're immature, that means usually these guys will have no apoptosis, they can't die. And they will doing what? They will start accumulating where? In bone marrow. Now, technically, bone marrow is supposed to be 50% fat, 50% blood cells. 50% fat cells, 50% blood cells. Okay? If you have too many immature cells that have no function, they're defective by nature, that means they overcrowd. Think about it, in this room, we have what, 40 students, right? Somehow, immature version of us, let's call them aliens from Mars or what? Let's call it from Venus, not Mars. Okay? So let's say we have these aliens coming, they're all abnormal, and there's 1,000 of them, and they fit in this room. What will happen to us? They will squish us and we'll die, we'll suffocate. This is called bone marrow suffocation. So these immature cells will start suffocating which cells? The normal cells. And what are the normal cells? Red blood cells, platelets, and other white blood cells. The most important white blood cell is, of course, neutrophil. Now, at the end of the day, isn't that the same thing as bone marrow failure? Yeah. Because the function of bone marrow is to produce viable, active, functional blood cells. And if there's other cells that are killing those normal cells, bone marrow is failing. So now, the term that's used for that is pancytopenia. Pan? What does pandemic mean? Global. Spread, global, but global. The entire region. Pan means all blood cells are affected. What does cyto mean?
Cell.
I like to color code it for you. You know, so that way we can think like we're in kindergartens. Penia means?
Decrease.
Decrease. Very good. Cyto means?
Cells.
Cells. And then pan means?
Global.
All. All blood cells are decreased in number. And what do we mean by that? RBCs, of course. Platelet count, yes. And white blood cell count, all counts are low. So what is the function of red blood cells? Carry oxygen. And if you have less number of RBCs, what would you experience? Anemia. Excellent. Anemia, anemia, anemia. So pancytopenia will give you what? Anemia. And then platelet count. What is platelets for? No, that's abnormal. Prevent bleeding. Prevent bleeding. Coagulation, yes. Clotting, yes. But we don't use that. Those are abnormal terms. Platelet prevents bleeding. Clotting and coagulation can become abnormal, can cause problems. See, platelet have a normal function, just to keep you safe, prevent you from bleeding to death. So now if you have low platelets, what happens to cuts and wounds and rashes? They won't heal, and they will bleed more frequently. So easy bruising and frequent bleeding. Easy bruising, frequent bleeding, because a platelet count is low. RBC count leads to anemia. Less RBCs leads to anemia. Low platelet count leads to easy bruising. You're not going to spontaneously bleed. You're like, let me think about it. Huh? Hey body, please bleed. It doesn't work like that. That means when you hurt yourself, you can have a rash instead. You know, when blood leaks and you will have purple rash, that's because of platelet, lack of platelets. So you can have purple rash, easy bruising. Rash and bruising the same thing. Easy bruising and frequent bleeding. Now let's go to white blood cell count. When they're low, what happens? Increased risk of infection. Increased risk of infection. So look for those three things. In terms of symptoms, fatigue, bruising, and fever. That's what you should look for. I mean, that's ALL. All leukemias should act like that, especially acute leukemias, okay? But it's common in children. So I hope you understand that. Maybe. Now, if you remember that, I did talk about lymphocytes when we talk about tissue, connective tissue. Do you remember that? I showed you a picture of them. What does it mean? Write it down. So I remember. At least he has to write it down. On the exam, I might show you a picture, and I'll show which of the following cells number will increase in Down syndrome patient. I just give you a clue. Okay, and you should pick lymphoblast or lymphocytes, not neutrophils, not granulocytes, not RBCs, not platelets. They should decrease.
Because of ALL.
Exactly. Because the connection is the only connection we have between blood cells and Down syndrome is what? ALL. Okay. See, Down syndrome questions will not be just plain questions. It's usually about complications of it. Alzheimer's. Now, if I ask a question about Alzheimer's in Down syndrome patient, why am I not taking advantage of this whiteboard? Let's write here on top so I have more room. Alzheimer's disease. Alzheimer's disease. Let's focus on A. A for all. A for all. A for all. And let's focus on A. In Alzheimer's, all of the brain, I mean, it's not a good term in that sense, but just makes sense. Entire brain, all of the brain is atrophied. In Alzheimer, the entire cerebral cortex atrophies. It shrinks in size. Okay? All brain atrophy. All brain atrophy. Alzheimer's. All brain atrophy. The entire cerebral cortex atrophies, shrinks in size. And in mass. Of course, that means less functionality. It's not one region. It's the entire brain or cerebrum. But subcortex is saved. Let's ignore that for now. Just know that Alzheimer for entire brain, all brain shrinking in size or atrophying. Also, acetylcholine deficiency or decrease. Acetylcholine, which is a neurotransmitter. It makes you alert. It makes you build memories. It makes you think. It's the major stimulatory hormone, neurotransmitter of the CNS. So that's deficient in Alzheimer's. Okay. Some people say all go down. Alzheimer's, Down syndrome connection, all go down. I don't know if that helps you. So for Alzheimer's, at the end of the day, Alzheimer's patients will be all mental problems. Meaning, can they speak properly? So their language is deficit. So let's go again with A. Aphasia. Aphasia. Language deficit. That's what aphasia stands for. So again, we'll focus on what? A's. Aphasia. Language deficit. Now, language is not just speaking, it's understanding as well. Okay, language is not just speaking, it's also understanding. You can speak, but if I tell you something and you don't respond to me right, that means you didn't understand me. You have language deficit. Okay, so language is a speech problem and it has understanding problem. Component, not problem. They will have also amnesia. Amnesia means lack of memory. A means without. Aphasia means language. A without language. Amnesia means memory. A without memory. Okay. Apraxia. Skilled movement, purposeful movement. Okay. What else? Agnosia. Oh, I love you guys. That's good. Agnosia. Good job. What does that mean? Knowledge. Knowledge. Lack of knowledge. Lack of knowledge. Okay. One more. There should be 5 A's. Achalasia? Huh? No. Aphasia, language. Amnesia. Apraxia, movement. Agnosia, knowledge. There's one more. Okay, at the end of the day, the entire brain is affected. It's a global deficit for Alzheimer's patients. I don't remember that one, but
it was 4 when you thought it was 4.
I thought you wrong. Oh. I was experiencing Alzheimer that day. Huh? Anapsia? Like taking anopsia. No blindness. I'll think about it, but 4 is good for now. Unless I'm just making up stuff, you never know. You never know. I'm expecting more, but yet there's only 4. So please remember that. With Down syndrome, I could also ask about, Down syndrome is more common in our society compared to Edwards and Patau. So you're likely to get more questions on Down syndrome, but detailed questions. So what's the other complication of Down syndrome? We talked about that, cardiac defect. Let me just quickly go over ASD. ASD. Okay, ASD. Now for ASD, I have to draw a heart. And you have to be patient with me. Let me finish it. I'll come back to you. You said fungi? This is a heart. It's not a fungus. Mohammed?
Dr. Munir.
Yeah.
Lack of interest.
A what?
Lack of interest. Aphasia.
Lack of interest?
Yeah. Interest of what? It's here.
No.
No.
Is it?
Yeah.
Okay, then it's true. I like your enthusiasm.
What is it? Anomia?
And anosmia, yeah. Inability to name, yeah.
But isn't that a language thing?
No, it's memory, language, everything.
So anosmia means consent.
Yeah. And osmia means smell.
Alright.
Yeah. Okay. Elogia means without naming, not able to name. And osmia is smell. It's not always there. It's not true in Alzheimer's. Okay, so look, we're talking about ASD. Now think of here, blue side should be, the blue side should be what? The right side of the heart. Blue side should be the right side of the heart. You should have only two vena cavas, inferior and superior vena cava. Blood should be coming from inferior and superior vena cava into the right atrium. Good? And still blue blood, right? It's still blue blood. It's deoxygenated blood. And this deoxygenated blood should go where? Very good. So this will be the right atrium. And this is right ventricle. So blood should be received by the right atrium. From there it should go where? Right ventricle. I should have used blue, but anyways. Okay. This blood should go to lungs. And then from lungs it will come back to the right side of the heart. And the right side is left ventricle and left atrium. Very good. And eventually go to aorta. Now the thing is, when it comes to ASD, where is it? When it comes to ASD, there is a bypass of lungs. So blood doesn't have to go to lungs. So there's a communication. Okay, in this communication, because blood is only coming to the right heart, so that means there's more blood coming here, and you will have less blood in the left atrium, so all of this will go from right to left. The shunt should be from right to left. Okay, because a lot of blood is coming to the right side, and then from there the left chamber is usually empty, will go there, because left chamber from there will go to the body, will be pumped. So it'll always be from right to left during embryological development. If this thing doesn't close, it should close after birth. If it doesn't close, if it fails to close, then you call this defect. It's supposed to close. If this opening does not close, it's defect. And this defect is in what? In the septum. And the septum is located where? Between the two atria. So you'll call it atrial septal defect, or ASD, which is more common in Down syndrome. Out of all of them, more common than VSD, more common than PDA. Yeah.
They'll also have anemia because of this too.
Very good. Now we'll go to the symptoms. Okay. Now, so the thing is, you have heart sounds. Your heart produces sounds. First heart sound and second heart sound. Are you okay with that? We did it? Excellent. So Shukrullah went over it, right? Okay, so somebody says, no, that's good enough for me. No. Okay. Now, the S stands for sound. S stands for sound. S1 is produced by... How many valves do you have anyways in the heart? Four valves. 4 valves. Let's talk about the valves first. The function of valve is to prevent backflow. That's all. Valves are designed to prevent backflow. And let me tell you what it means in this sense. Blood is supposed to only come to the right atrium, go to the left ventricle. True? This is one directional flow. From here it's supposed to go to lungs. From lungs it will come to left atrium, from left atrium to left ventricle, and then out of the body. Blood can only come to the heart and leave. From one end it will come in, from other end it will leave. It never comes from both sides. So that means there's only one directional flow of blood. It's always from right to left. Blood flow is always from right to left. Always from atria to ventricle. Always from ventricle out. Atria receives, ventricle sends it out. Okay, so I'm sure all of you guys have taken heart anatomy and physiology somewhere. If not, you probably remember from when you were a baby in your mother's womb, because I remember. Anyhow, okay, now, so if blood is flowing in one direction, if the whole purpose of the heart is to pump forward, you don't want to work so hard to pump forward and then send it back in. Therefore, you have valves to prevent this backflow. So the function of valve is only one thing, nothing else. Please remember that. It's only to prevent backflow, backflow, backflow. Valve does only one thing, to prevent backflow, backflow, backflow. Are we good with that? Okay. Now, when valves open up, and then there's high pressure on the other side, and then that pressure pushes it and shuts him. Boom. It's the first heart sound maybe. So it's the closure of the valves that produces the sound. It's the closure of these valves that produces the sound. Are we good so far? Number one, valves produces heart sound. Number two, valves are only for one purpose, to prevent backflow. Okay, to prevent backflow. Now we have 4 valves. 2 of them is known as AV valve, between the atria and ventricle. Left AV valve and right AV valve. And then we have pulmonary valve and aortic valve. Good? 2 valves prevents backflow into atria. The other 2 valves prevent backflow into ventricles. The atria contract at the same time, the ventricle contracts at the same time. Okay, that means 2 valves will close at the same time and the other 2 valves will close at the same time. All 4 valves cannot close at the same time. The AV valve will close at the same time. So that will produce the first heart sound. Closure of AV valves produces S1. Closure of AV valves produces what sound? S1. Closure of aortic and pulmonary valve, which are known as semilunar valve, produces the second heart sound. Are we good so far? Okay. Now, the thing is, the first heart sound is much louder because it's the closure of AV valves. The ventricle has a lot of pressure on them. Aortic and pulmonary arteries don't have that much pressure on them. So the first heart sound has to be loud. The second heart sound should be a little bit low pitch. But I'm not talking about that. I just want to have to give introduction now. AV valve has how many components? 2. Mitral component and tricuspid component, because it's made of 2 valves closing at the same time. Try to clap with me at the same time. 1, 2, 3. See, it's supposed to produce one sound. What if one valve closes early, one late? How many sounds would you hear? 2. And that's called, for that one sound, it will be split into 2, and that's called splitting of S1. So when 2 valves, the 2 AV valves, don't close exactly at the same time, it's called splitting of S1. If the semilunar valve don't close at the same time, it will be called splitting of S2. With ASD, you have splitting of S2. Splitting of S2. Splitting of S2. Now this is not before birth, this is after birth. We're talking about after birth. So now, how is that so? And I'll tell you now. Okay. So first of all, there has to be a communication, right? Between the 2 atria. So there is transatrial blood flow, correct? Okay. After birth, blood goes from here to lungs. And from lungs, it will come back where? Into the left atrium. Now in the left atrium, there's high pressure. So that means blood will leak where? That's why I did the red now. See, before birth, blood flow is from the right to left through that atrial septum. After birth, it switches. It switches. It comes from left to right. So that means this oxygenated blood will come mix up with here. Okay, and vice versa. So that means there's more blood, and there's more blood coming here. That means through pulmonary valve. Okay, let me put it this way. Hopefully this would help. Let me use my arrow. I'll use green. So blood comes here. From here it will go this way and it will go this way. Now the blood is split. Instead of all blood going in the direction 1, there's some blood that will go in direction 2. You want all blood to go in direction 1. Okay, from here blood will go through aortic valve. Aortic valve. And from this ventricle, from the right ventricle, will go through pulmonary valve. Blood flow through aortic valve just decreased in this patient only. Blood flow through pulmonary valve just increased in this patient, which means pulmonary valve will stay open longer because there's more flow through it, and aortic valve will close much earlier, and as a result you'll get splitting of S2. It's typical of all ASDs, and remember that. Okay, so number 1 sign, and I hope you write it down to remind you because I'll test you on it. Number 1 sign that will help you identifying ASD is what? Splitting of S2, and that's fixed. So we have two terms. You understand what splitting comes from, right? Do I need to explain splitting? No. Let's talk about fixed. Fixed means it doesn't vary with inspiration. When you inspire air, it doesn't change the frequency of it or intensity of it. Okay? It's fixed. But in circumstances when you inhale air, what happens to your abdomen? The pressure should increase there, and that should push blood more, and it will cause it will vary with inhalation. In exhalation should be low pitch, and in exhalation it should be high pitch, but in this case it doesn't happen. So for ASD, always remember there's splitting of S2, there is splitting of S2, which is fixed. Fixed in this term means it does not vary with inspiration. It doesn't vary. It stays constant. It's the same intensity whether you expire or inspire air, don't matter. Okay, so that's one thing. Second thing, you will have murmur. Murmur, the term murmur refers to abnormal blood flow. You know, when you go to a lake compared to a waterfall, what's the difference? Sound. Waterfall produces a sound. Why? Because the water flow is rough. It's rough. In a lake, water flow is smooth, so there's no sound. So murmurs are abnormal sound produced by abnormal blood flow or turbulent blood flow. Turbulent is a better term. Not smooth flow, turbulent blood flow. Murmur is a sound produced, it's abnormal sound. Murmur is abnormal sound produced by turbulent blood flow. You shouldn't have murmurs. At least not above 3rd degree. We'll discuss it in cardiology, but know that for now, just know that murmur is abnormal sound produced by abnormal or turbulent blood flow. If you have more blood flow through this pulmonary valve, don't you think it will produce sound? You know, if you open your faucet and you medium open it halfway, it doesn't produce so much sound, but if you increase it, shh, that's murmur. Shh, 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 that's murmur. Somebody agrees with me and they're calling me. Nice. Okay, now, so to identify ASD, you're going to focus on what? Splitting of S2, that's fixed. Fixed splitting of S2. And murmur. And this murmur has to be heard where? In the second intercostal space left of sternum. Write it down. Because it's pulmonary valve, it's located in a different region. So murmur, it is systolic murmur, number one. It is systolic ejection murmur. Systolic ejection murmur. Systolic ejection murmur. Systolic ejection murmur. And I'll tell you what that means. Let's write it down first. Systolic ejection murmur. You're like, oh, I hear abnormal sound of blood flow only during systole. That's what it means. Systole means ventricular contraction. Ventricular contraction. So you'll only hear this abnormal sound of blood flow or murmur during systole. So you call it systolic murmur. It's ejection because it's through aortic or pulmonary valve. It's not regurg, it's not backward. It's ejection, forward. It's caused by forward blood flow, not by regurgitation, not by backward flow. If the valve is loose, it will be backward flow. Okay, so that's one. Systolic ejection murmur. You hear it best in the second intercostal space. Left of sternum. Very good. Second intercostal space, left of sternum, which is right here. Yeah.
Is it left of sternum from the patient's view or the doctor's view?
Patient's. Not on view, on location.
Right, so it is left like...
You're not going to put the stethoscope on your sternum. You're going to put it on patient's sternum. So left of patient's sternum.
Left of, from your perspective.
So they're
No, they're left. They're left.
They're left, okay.
Yeah, they're left. I understand what you're saying. I'm like, why do we give patient a choice to have perspectives? You just do what you need to do. Yeah, patient's left. Left of sternum on the patient. Okay? Yeah. So now the thing is, now somebody said, would this cause anemia? Of course. There is hypoxia. There's hypoxia. It's not anemia, but it's hypoxia. Anemia means defect in RBCs. This is not defect in RBCs. This is defect in oxygenation because there's mixing of blood. So lead to hypoxia. Okay, lead to hypoxia. So look for ASD. Again, two things. Please remember there is transatrial blood flow. Transatrial blood flow. Number one. transmit within the two atrium, and there shouldn't be any communication between atrium. And there's mixing of blood. Oxygenated and deoxygenated blood mixes up. Okay, so there's mixing of blood. You know, oxygen will always go from where? From high concentration to low concentration. So if you have red blood on the left side and blue blood on the right side, blue is deoxygenated and red is oxygen, isn't it natural that oxygen will go from high, from red to low? Yeah. So you lose some oxygen. You work so hard to grab it from lungs, but now you lose it. And at the end, tissue doesn't get enough. Okay, so, but focus on murmurs, focus on murmurs, focus on murmur. And the heart sound. Second heart sound is split and it's fixed. Okay, but there's murmur, which is systolic ejection murmur, left of sternum in the second intercostal space. Each murmur, you can only have 4 murmurs, right, in the heart. Either one valve, there's 4 valves, 4 murmurs possible, but you can duplicate it because it could be ejection or regurgitation. So 4 possibilities, and you know the 4 locations. So it's very easy. Okay, we'll go over that, but please be able to identify this. So that's for Down syndrome. Now you will have one question for sure on pedigree. You will for sure have a question that is a pedigree you have to interpret. A pedigree question. Okay. Now let me give you some. Most likely I will have it on X-linked recessive or autosomal recessive, but I don't know. If I forget what I told you, I apologize in advance. I'm just telling most likely I will do that, but you got to know the pedigrees. So mode of inheritance, we have autosomal dominant, autosomal recessive, and we have X-linked dominant and X-linked recessive. Okay, so these are mode of inheritance. Autosomal dominant, there is no skip generation. Every generation will get it. Not necessarily they will get a disease, but they will get the mutation. Every generation will get what? The mutation. Will get that abnormal gene. Every generation will get it. Okay? And if you get one copy, you'll express it. So you need only one copy. A single copy of a gene will cause mutation or a disease. You don't need 2 copies. Okay? When it comes to autosomal recessive, you have what? Look, we have all of Friday as well to review, so I'm going slowly over everything. Okay, so if you have question, ask me. You said skip generation? Excellent. So autosomal recessive will have skip generation. Skip generation. Huh? Very good. And let's go with the second point, and then we'll go with the healthy parents. You need minimum of 2 copies.
What does that say?
Single copy of a gene will cause the disease. You know how many copies of each gene do you have? 2. In autosomal dominant, even if you have a 1 copy that's defective, it's enough to express a disease. Very good. Now in autosomal recessive, both copies of the same gene must be mutated in order for you to express a disease. So let's say this. What is the relationship of genotype to phenotype? Okay, phenotype is expressing a disease. Genotype is genetic makeup. So in autosomal dominant, if you have both capital A's, the disease inherited in the dominant fashion, you have both genes dominant, that means you will have the disease 100%. But these patients don't survive, they die. So it's rare to find the most dominant form of a disease, because that means all the children will have it. So such people don't exist. Usually they die. But let's say you have a carrier state, right? A carrier state. In a carrier state, 50% of the children will have mutation, 50% will be healthy. So even if you get a single copy, look, you have 1 normal copy. I'll color it with green. You have 1 normal copy, and you have 1 abnormal copy in red. This abnormal copy by itself is enough to cause a disease. Okay, so in autosomal dominant, you just need 1 abnormal copy of the gene to cause a disease or a defect. But let's go to autosomal recessive. Autosomal recessive disease are inherited in the recessive fashion. If you have autosomal dominant, this is completely normal, best option. And if you have a carrier state, guess what? This is normal as well. Phenotypically, genetically it's abnormal, of course. So genotype, that is A, capital A, small a, for recessive disease is abnormal, but phenotypically it's normal. For autosomal dominant disease, genotype large A, small a is abnormal. Phenotypically it's also abnormal. Make sense? Okay. The only way you can have a disease in the recessive fashion is if you have both copies abnormal. One copy is not good enough. It won't cause a disease. Difference between dominant and recessive is that. Okay. Let's go. Now, the next thing is recessive diseases. Normal parent. Normal parents can have abnormal child. Normal parents could have abnormal child. Let's say both parents are carriers. If both parents are carriers, carrier state is phenotypically normal. Genetically it is abnormal. You're carrying a gene, one copy, and one copy is not enough. So if there's two carrier parents, phenotypically they're normal, genotypically they're abnormal, but they can give you a son or a daughter that is diseased, and the risk of that is 25%, or the chance of that is 25%. Okay, but in autosomal dominant, such thing is not possible. Normal parents can never give you a diseased son or daughter or child, because if either they have it or they don't. If they have one copy, you will see it in them. They will express it. If you don't see them diseased, that means they don't have abnormal gene. They have no abnormal copies. Because even if you have one copy, you will express the disease. So normal parents can only give you normal children in dominant fashion. Good? Okay. In both cases, male to female ratio is equal. Men and women are affected in the same rate. That's an autosomal. Let's go to X-linked. Let's go to X-linked. Now X-linked dominant. So number one thing when we go about X diseases, male to male transmission is not allowed. There's no such thing. Dad can never give the disease to their son. Never. Never, ever, ever. Because look, you only get one X chromosome. You can only get one sex chromosome from dad. You have only two options. You get X or Y. You don't get both from dad. If you get X, and that means it's daughter. If you get Y, it's male. I mean, if you don't get X, you get Y, and that's automatically male. So male will never get an X from his dad. Daughter could, but man cannot get it. So there's male to male transmission is not allowed. Rule number one for X-linked diseases, not just recessive, dominant, both. In any of those two cases, X-linked dominant or recessive, male to male transmission is not allowed. It doesn't occur. Okay? Because gender depends on who? On dad. If the dad donates you a Y chromosome, you'll become male. If a dad donates you X chromosome, you'll become a female. From mom, you can only get one chromosome, that's X, because she has two copies of it. She has no Y. Okay, so that's one thing, but the rest of it, it acts just like autosomal dominant. X-linked dominant just acts like autosomal dominant. The only difference is there's no male to male transmission. There's no male to male transmission. The rest is exactly the same as autosomal dominant. If you just get one copy, of course you're gonna have the disease. Whether you're male or female, it don't matter. Okay, the only thing that will help you is male to male transmission is not allowed. Yeah.
So when you say type, is there a specific rule if it's not labeled, whether it's autodominant or autorecessive, or it's an upper or lowercase letter?
No. The uppercase and lower letter are accepted in scientific community, so you can use uppercase letters for dominant conditions and smaller letters for recessive conditions. Yeah.
I mean, is it something that we need to assume
Yeah, I'll give you a pedigree. Because once you look at pedigree, it depends what information is given to us. If I give you information that's not enough, you're going to choose an option that will say not enough information. Okay? So I will not give you something that doesn't make sense. Okay, so if there's not enough information, you'll choose that answer. But if there's enough information, choose the appropriate answer. Okay, once we do some pedigree, will help. Recessive. Now here, the transmission of this disease or inheritance of this is much more common in men than in female. And the only reason for that is men will have only one chance to get X chromosome. If they get the disease, they're likely to get it. Female, they can get one normal, one abnormal. Still they're normal because it's recessive fashion. In order for the disease to be expressed, you must have both abnormal copies. Female have 50% less chance of getting, both copies. What is the chance of both copies being recessive? Very rare. These are all rare diseases. But for men, they can, if they get one abnormal copy, they're done. So it's always in children, in boys, always in boys. X-linked recessive disease always occurs in who? In male. Always. You just have to assume that. There is exceptions, of course. The only time, look, a son of X-linked recessive parents that are carrier, normal parents can give you what? Abnormal son. Right? Normal mom can give you abnormal son. But abnormal dad can never give you abnormal son. Does it make sense? If dad is diseased, their sons will never be diseased. And it's common that if a dad has a disease, the daughters will be all normal and the sons have to be normal because they will never get the X chromosome. The only time a daughter will get a disease is if the mom is a carrier minimum and the dad has to be diseased. In X-linked recessive diseases, dad must be diseased in order for a daughter to get a disease. Must. There's no exception. Does it make sense?
So not just a carrier.
Dad can never be a carrier.
Yeah.
Dad can never be a carrier because dad has only one copy. Carrier means two copies, one abnormal, one normal.
What's the percentage? 80-20, 90-10?
50.
No, I'm talking about the percentage between male and female to be diseased.
No, it depends. Depends what is the genotype of each. Okay, if the mom is diseased and the dad is diseased, 100%.
Right.
If the mom is diseased,
No,
I mean,
population now.
in population there's no,
There's no.
yeah, it's, if the dad is diseased and the mom is completely healthy, it's different. So it depends on the mom's genotype.
Like color blindness.
Color blindness is one of them, yeah. But they're rare. All these are rare. They're usually 1 in 20,000, 1 in 30,000, 1 in 100,000. Extremely rare diseases. Okay. Mitochondrial inheritance, you only get it from who? From mom. You only get it from mom. But all children, let's compare mitochondrial and X-linked. X-linked recessive and mitochondrial diseases.
What about X-linked dominant?
X-linked dominant acts just like autosomal dominant. The only difference is that male to male transmission is not allowed.
It's not like mitochondrial?
No. No.
Not all cases are affected.
No. Because if the dad is diseased, you can get it from dad. X-linked dominant, you can get it from dad or mom. Mitochondrial, you only get it from who?
From
From mom. Okay. So X-linked dominant, you can get it from both parents. You can get it from both parents. Now, mitochondrial disease, mitochondrial disease, you only get it from mom. You only get it from mom, and all children will have it. Not 1 or 2 or 3. If a mom has it, all her children will have it. Okay. X-linked recessive, you only get it from mom as well. Okay. If it's a boy, okay, but only boys will have it, just for simplicity. But if dad is diseased, the daughters can have it too. Okay. All right. Imprinting. Are we okay with imprinting? Remember, in imprinting, there's 2 things that must occur. One is there must be a deletion. There must be a deletion. The second thing is there must be imprinting or methylation. So because we have 2 chromosomes of each chromosome comes in pairs. and imprinting is known for chromosome 15. Okay, let's label this. This is paternal chromosome and this is maternal chromosome number 15. Are we good? And I'll call this red. So the paternal chromosome 15 gene is deleted. It's deleted. Okay, so there's a deletion on the paternal chromosome. On the maternal chromosome there is methylation. I'll put M. What do you think would happen in this case? What conditions will come? Prader-Willi. Always focus on the deletion. If deletion is on the dad, it's Prader-Willi. If the deletion is on the mom, Angelman. Okay? Alright. Anything that you want me to, because we have Friday as well, we'll go over these things. Any questions? Are you okay with insertion, deletion, addition, missense, nonsense, and silent mutation? You okay with all of those? Okay. In frame shift? Very good. So study those once more time. Okay, so there will be a few questions on mutations. Okay.
Dr. Mania, what about point mutation?
Point mutation means a single nucleotide. It could be insertion or deletion.
So if we have in the answers, for example, is it silence or deletion, insertion or point mutation, what will we choose?
Okay, let's do this. Let me give you GAA. Okay, and this mutation occurs such that it's GAG. The only change that occurs in the third nucleotide, right?
Yeah.
That means at the end, let's say this code encodes for alanine and this codes for alanine. Good? And the switch was only one nucleotide. This is a point mutation, but this is a specific type of point mutation. This is known as silent mutation. So if you have this option and B you have point mutation, now you'll have to pick this one. This is more specific. Make sense?
Yeah, Doctor. Mazel told me that you want to talk to us.
Yeah.
I'm sorry. Yesterday, I had a few things to do after I came from Egypt, so I just didn't sleep until like 3 o'clock. And also, I just want to get to the bottom of that. Of course, mashallah.